for the best possible results. How far would you travel? Would you take an international flight to find a hospital that ranked among the very best in the world for the treatment of heart attacks? For the best possible results in 9 cardiac care measures, just how far would you go? St. Tammany Parish Hospital, world-class healthcare, close to home.
Welcome to Healthy Living, brought to you by St. Tammany Parish Hospital. I'm your host, Amanda Paxton. Antibiotics have become a staple in today's society, and many of us often request them from our doctor at the first sign of illness, thinking that this is the fastest way for us to get better. However, this has led to an overuse and resistance of antibiotics. Today we have a few guests here to discuss an antibiotic stewardship program that has been forming throughout the country and at St. Tammany Parish Hospital. Our first guest is Dr. Michael Hill, the Medical Director of St. Tammany Quality Network and an infectious disease physician. Welcome, Dr. Hill.
Thank you, Amanda.
Can you tell us a little bit about why antibiotic resistance is such a problem?
Well, it's been a problem for the last 40, 50 years. You know, penicillin was introduced in the 1940s, and over time bacteria have mutated and become more resistant to the usual antibiotics that we used to prescribe. And as it turns out, many of the old antibiotics that we used to use are no longer effective. And the reason why that's important is when we get sick with a bacterial infection, we need, and we're used to having antibiotics to have effective treatment to cure the bacterial infection. As resistance develops, some of these antibiotics may not be effective, and as we're finding out, worldwide and even in the United States, we're having so-called superbugs, or bacteria that have mutated to the point where routine antibiotics may not be effective. And there may become a day where we don't have any antibiotics to treat some of these more aggressive bacteria.
Oh, wow. So how was antibiotic stewardship started?
Antibiotic stewardship was started at St. Tammany Parish Hospital about 3 years ago. It's a group effort with a clinical pharmacist, an infectious disease specialist, that's myself, the hospitalist at St. Tammany, an infectious disease preventionist, Leslie Kelt, and we're constantly monitoring antibiotic use in the hospital to make sure it's appropriate to take the patients off antibiotics when it's time to take them off, and to make sure that the appropriate antibiotic is being used.
Okay, and what's the purpose of this program?
Purpose of this program is to make sure that we don't develop superbugs within our hospital and within the community. We want to make sure that we're preserving antibiotic use for the future, for our children and our grandchildren.
Okay, how did STPH institute an antibiotic stewardship program?
About 3 years ago, 3.5 years ago, a committee was formed at St. Tammany that included the chief medical officer, and we had read a lot about the purpose of in the improvement in antibiotic usage with antibiotic stewardship programs that were beginning all over the United States. And at that time we formulated a committee and began a systematic program that would look at antibiotic use within our hospital. And as a hospital, community hospital, we've actually pushed this out into the community as well. And as I say, it's a multidisciplinary team that meets once a quarter, but actually we're looking at antibiotic use at the hospital every single day.
Okay, can you tell me a little bit about the Bug Club that y'all started?
Yeah, the Bug Club. It was an interesting name. We thought of a lot of fancy names. Bug Club was about the best we could think of. It's a group of physicians and pharmacists and infectious disease specialists and our lab microbiologists that meet once a quarter to discuss antibiotic issues or new bacterial issues or efficiency issues within the hospital, and it's in the entire North Shore region. So it's headed up by St. Tammany Hospital, but we like to share information with our colleagues and find out what's going on all over the parish.
Okay, and so do you think that this antibiotic stewardship and kind of stopping the resistance and that sort of thing, is that a change in culture that needs to happen in the United States, in the world, or?
Well, certainly in the United States and in our community first. And it's a lot of preparation when a patient comes into the office explaining why they're not going to receive an antibiotic for a cold, a viral infection, or allergies, that sort of thing. It is taking off in the country. The CMS, which heads up Medicare and Medicaid, is going to be changing some of the rules for hospitals, making it a requirement that you have an antibiotic stewardship program within the hospital. And then worldwide is more problematic because many third world countries you can still go get an antibiotic over the counter without a prescription. And so we've seen a lot of resistance in some of these countries that have that practice, and those patients end up coming to the United States, or those bacteria end up making it to the United States, and then we have a problem that develops here.
Okay, and so what is the target of the antibiotic stewardship program?
Well, it really is two-pronged. One is in the hospital to make sure that patients that don't need antibiotics don't receive them. Sometimes it's hard to distinguish an infection from a non-infection. Once we determine that this is not caused by an infection, we'll take the patient off antibiotics. We like to look at what is an usual course of treatment, so making sure that the patient doesn't receive more antibiotics than they need, and also when the patient is discharged, what antibiotics they'll go home on if they need that. The other prong is to push out to the community and to our community physicians and our patient base and explain the importance of using antibiotics judiciously so that we have them in the future.
Okay, awesome. And then can you tell us a little bit about maybe some specific diseases or issues that deal with antibiotics?
Well, we're seeing more and more changes in resistance patterns, and things that we used to use, antibiotics that we used to use years ago are no longer effective. What we're doing with some of the newer antibiotics is putting them off, their use off for as long as possible, and only using them in very specific situations so that we have them in the future. And one of the reasons we're doing this is to prevent side effects of antibiotics, such as antibiotic-associated diarrhea or C. diff, which we're seeing a lot of in the community. Most of this is related to antibiotic use, and therefore it's important that we make sure that when we give a patient an antibiotic, it's for the right reason.
Okay, great. Well, thank you so much for being here with us today, and I think this is really important for the community to understand because, like I said, a lot of people go straight to the doctor and say, give me an antibiotic, even if it's just a little cold.
Right.
So thank you so much.
All right,
and
thank you.
Up next, we have Ashley Wilson, a clinical pharmacist at St. Tammany Parish Hospital, to give a little bit of her perspective on antibiotic stewardship.
Thank you. Thanks. Thank you. Thanks for Sunny Face Eggs for my baby sister.
For my fishing buddy.
Thanks for my mama's gumbo. Thanks for my mom.
We enjoy receiving awards and recognition from our peers, but the true reward comes from seeing positive outcomes for our friends and neighbors. So thank you for trusting us. St. Tammany Parish Hospital, world-class healthcare close to home.
Our next guest is Ashley Wilson, a clinical pharmacist at St. Tammany Parish Hospital, here to give us a little insight into the clinical pharmacist's role in an antibiotic stewardship program. Welcome, Ashley.
Thanks. Welcome.
So can you first tell us what the pharmacist's role is in antibiotic stewardship?
Well, as a pharmacist, I review patients' charts daily just to make sure they're on the appropriate antibiotic. And then I also look at what dose they are on, making sure it's appropriate for their renal function, because a lot of the doses can cause, or a lot of the drugs can cause toxicities if it's not in the right range. So we do therapeutically monitor the patients. Another thing that we look for is we do IV to PO conversion, just meaning that if a patient is on IV antibiotics or even something as simple as Protonics, we try to switch them to PO or a tablet form as soon as possible. So as long as they meet the criteria, we do switch patients from IV to PO therapy. We also educate the staff and patients about different initiatives that we have going on about antibiotic stewardship and their medications.
Okay, and so why target antibiotics?
Mainly because of the increased resistance. There's, as Dr. Hill had said earlier today, resistance is growing, and unfortunately we have fewer and fewer drugs coming out to treat these superbugs. So we really want to save the drugs, that we have for those really bad infections. So that's really one of the big reasons. Another thing is just the adverse drug reactions and the complications that can occur with using antibiotics.
Okay. How often do complications occur in patients?
Actually, 5 to 25% of the time they cause complications. Now, some of them can be mild, just a little stomach upset, but it could be severe as far as like a rash, where Stevens-Johnson syndrome, where you kind of have the sloughing of the skin. So there's a very wide range of events that can occur, but they do have side effects.
Okay. What about emergency department visits? I know misuse of antibiotics can cause some of that.
Yes, actually, 1 out of 5 emergency department visits caused by a medication-related event is actually from an antibiotic.
Okay.
So.
And can you give us some examples of what can cause that?
Yeah, for instance, fluoroquinolones, it has drug interactions with heart medications where it can increase your QT prolongation, so it kind of makes your heart palpitate a little differently and can cause serious adverse events. Some can be simple, like with doxycycline. It interacts with the sun, where you can get a rash from having photosensitivity because it makes your skin more sensitive to the sun. So those are just a couple. And even with macrobid, which is a common one that they use for UTI, can cause nerve, lung, or kidney damage as well.
Okay. Can you give us a little information about C. diff and why that's important?
Yes, C. diff is Clostridium difficile, and it's a bacterium that actually is the cause of anywhere from 15 to 25% of antibiotic-associated diarrhea. I know diarrhea is the fun topic, but
it's important though.
Yes, it is, because it's actually the most serious, one of the most common adverse effects, where the patients become so sick. There's actually been up to more than 29,000 deaths because of C. diff, and 15,000 of those deaths were actually directly attributable to the C. diff, where it was the primary cause of death. So it is very important. It's something.
Is that a bacterial infection that would usually be treated with antibiotics but can't be, or?
Yes, it's kind of a catch-22, because you get it from being on antibiotics, because it changes your gut flora, and then you treat it with, there's 2 antibiotics in particular that are used to treat it. So it's kind of like the antibiotics cause it, but you can treat it with a couple antibiotics. Not every antibiotic can treat it though.
Okay.
But unfortunately, the other thing, just hand sanitizer will not make it go away, because you have to, it's very easily transmitted from one patient to the other. So you don't want to just use hand sanitizer. You want to make sure you wash your hands with soap and water after you go to the bathroom, or if you go and visit somebody who has C. diff, you have to wear protective gear. So it's very serious, and we do take as much protection against it as that we can.
Okay, great. Well, is there anything else that a pharmacist does in regards to antibiotic stewardship?
No, we just do a little bit of everything, making sure, we don't want people to not use antibiotics. We understand that there are times where antibiotics are appropriate and you do want to use them, but you just want to make sure that we use them appropriately. So that's really the most important.
Okay. And is there a common saying that people usually say about antibiotics?
Yes, there is. So if you go to the doctor and get a prescription for an antibiotic, you'll get better in 7 days. But if you wait and you just ride it out, you'll get better in a week.
Well, great. Well, thank you so much for being here with us. And it's very interesting to learn all this about antibiotics, because people expect them instantly, I know. So
yes.
Thank you.
Thank you.
Up next, we have Dr. Sunil Pruitt. He is a urologist, and he will be discussing a little bit about asymptomatic bacteriuria and how that is interacting with antibiotic stewardship.
When it comes to your family's health, you want the best. That's exactly why St. Tammany Parish Hospital and Ochsner are now working together. By uniting 2 of the highest quality healthcare organizations in the state, we can bring everyone in St. Tammany Parish a higher level of specialty care with advanced procedures and the most advanced technology. Because when your healthcare is better, so's your life.
Welcome back to Healthy Living, brought to you by St. Tammany Parish Hospital. Our next guest is urologist Dr. Sunil Pruitt, here to discuss asymptomatic bacteriuria and its relation to antibiotic stewardship. Welcome, Dr. Pruitt.
Nice being here, Amanda. Thank you very much.
So in relation to asymptomatic bacteriuria, what have you seen in practice?
Well, right now the big push, Amanda, is to get away from antibiotics in the community, in practices, in the hospitals. We're trying to get away from having to treat everything as far as infections, urinary tract infections, other types of infections. We want to try to hold off on just giving back antibiotics, even with patients being asymptomatic. Because as Dr. Hill probably already have told you guys, the biggest issues are that of resistance. Mm-hmm. And when you got bacterial resistance to antibiotics, you're going to have problems down in the future. So we're trying to only treat symptomatic infections.
Okay. And so are antibiotics often overused when it comes to UTIs?
Yeah, they're very overused. I think a lot of patients will have symptoms, typical, infection symptoms of burning, discomfort, pressure, pain, and a lot of times it's not an infection causing that. It could be other things. And so for patients who are symptomatic, we generally recommend doing a urine culture with a urinalysis and actually identifying the bacteria. And if indeed they do have an infection, then we treat it. But a lot of the patients you'll find that who have irritative voiding symptoms, symptoms similar to those who have UTIs, they may not have an infection. And so just throwing antibiotics at them is not a good thing.
Right. So who needs a urine culture?
I think that anybody who's symptomatic, who has the pressure, pain, discomfort, a little blood in the urine, I would recommend getting a urinalysis and a culture. Any patient who's going to undergo a urological, an invasive procedure, you probably want to do a culture just to make sure. Pregnant women, for sure, you want to do a culture because you can have complications of pregnancy if they truly do have a urinary tract infection.
Okay, and so when do you treat the urinary tract infections?
In those situations, the patients who are going to be having an invasive procedure, pregnant women, any symptomatic male or female who has a urinary tract infection. So what we're trying to do is we're trying to distinguish the asymptomatic bacteriuria, which just means having bacteria in your urine and not having any symptoms. We're trying to distinguish that from true symptomatic urinary tract infections. Mm-hmm. Because asymptomatic bacteria, there's a big population that has that, and it will not cause any issues. The more you treat these things without the patients truly having a true urinary tract infection, could only cause problems down the road with antibiotic resistance. And then, there's only a certain number of antibiotics we have to treat these infections, and if we don't have those available to us, then we could have true problems down the road.
Okay. And so are there certain types of patients that you would not treat for a UTI?
Patients who come to me who have foul-smelling urine, who have cloudy urine, who say that the urine is just not right. You just don't throw antibiotics at them. Mm-hmm. You have to see what their symptoms are, and then you have to take a look at the overall picture as far as their clinical status. So if they're not having any urinary tract symptoms, they're just going by the qualitative description of their urine, the smell or the look of it, what have you. Then you don't want to treat those patients. And so anybody with symptoms, you want to do a culture, and just to make sure. A lot of times I'll find, I see a lot of patients who come in, they say, look, I know I have a urinary tract infection. We do a culture and it's negative. Then we do other workups, because a lot of times it could be anything from a bladder tumor or interstitial cystitis, abacterial cystitis. There's a lot of other things that it could be.
Okay. And what about like diabetic patients, elderly patients? Are those treated differently?
Well, if you go to a nursing home and if you do a urinalysis on majority of those patients, a lot of those patients have incontinence, and with their age, their hormone changes are there, and so they will have bacteria in their urine. That's a normal thing. There's nothing to worry about. If they're not having symptoms, there's no reason to even look at their urine. If they're having symptoms, then you do the appropriate cultures and go from there.
Okay. Can you tell us a little bit about Foley catheters?
Well, Foley catheters a lot of times can be a convenience, especially in the elderly population who in the nursing homes who have problems with incontinence. Ideally, you would not want to have a Foley catheter in a chronic situation. In other words, if you have an elderly lady or elderly gentleman who has problems emptying their bladder or incontinence, ideally you wouldn't want to have a foreign body in there, because ultimately you're going to get colonization, which is not a big deal as long as you don't sit there and chase the bacteria that's in the bladder. However, it can possibly lead to a true urinary tract infection. And statistically, we know that every day that you have a Foley catheter, there's a 5 to 10% increase in chance of having an increased amount of bacteria in the urine. And for a small percentage of those patients, they will have a symptomatic infection. So ideally, you don't want to have a Foley catheter, but there's some patients who they need one. They need either a Foley catheter through the urethra or a suprapubic catheter. For those patients, you just have to understand that they're going to have bacteria in the urine. There's nothing to worry about as long as they're not symptomatic. And when I say symptomatic, I mean, fevers, chills, a lot of blood in the urine, altered mental status, those things. And so you really have to look at the whole clinical picture. You can't just look at just one part of the picture and then, give them a diagnosis of a UTI and then end up just throwing antibiotics at them. Because you know why? A month later, they're going to be back with the same issues. If you culture your urine every month and you have a chronic Foley catheter, it's going to be positive. So.
Okay. Well, great. Thank you so much for being here and giving us some insight into this asymptomatic bacteriuria. I'd like to thank Dr. Hill, Ashley, and Dr. Pruitt for being here with us today and talking about antibiotic stewardship. This has been Healthy Living, brought to you by St. Tammany Parish Hospital. I'm your host, Amanda Paxton, and we'll see you next time.